meeting to order May 29, 11 a.m. Commissioner's Health Department, and I got my kid and her friend here, so and there's a couple of visitors on the online too, right? So, welcome. All right, motion to approve prior minutes.
So move.
Second?
Second.
All in favor?
Aye.
Yes. Motion passes. All right, we don't hear.
And I do believe that Chris is online, is that correct?
Correct.
We have the agenda.
I'm here.
No, I don't think we.
Okay, that's fine.
printed
We're
the
good.
Agenda, apologies.
No, we're good. Don't worry about it. All right.
But,
So we have a busy day with passing the budget because it's due by, was it June 1st?
oh, we did, yeah,
Oh,
great.
okay.
Well,
Thank you, sir.
Sal, I would just want to say, I want to give Monica and her team a lot of credit. Being dosed a lot of bad news financially, as we talked about in the last meeting. Her team went to work right away, didn't panic, and said, okay, we got to come up with a plan on how we're going to address these budget cuts. And really did yeoman's work trying to get all that done. And I think today, the reason we want to have this meeting so close to the last meeting was, as an organization, we don't like to let problems linger.
Yeah.
We want to come up with solutions and make sure the board's okay with this. So as the chair and the board, we want to get this in front of you guys to make sure we're all okay with this so that we can kind of move on. And there's some finality to it for our staff too. Like, okay, we know this is our new reality. Let's keep doing all the good work that we're doing. So that's the point of today's conversation, I think.
So, yeah, we're gonna talk about the overarching kind of budget
Mhm.
plan, but, and then we'll just seek your approval, and I sent it out yesterday, the official like HFI budget, because that's what has to be submitted to the state, by June 1, so,
June 1, okay.
yeah.
And that was because there was a big surprise budget cut.
Well, it would have to be approved and submitted to the state by June
Yeah.
1 regardless, but yes, there was a huge budget cut, so we shifted plans, so we'll talk through what we've shifted, what we've cut, what we've, and it'll be pretty high level.
And that's what the mayor was alluding to, that it was not us, but it was.
63% reduction.
73 of HFI, and then we
73%
had
reduction of new money.
large grant reductions as well from the
Yeah.
federal government. There's a lot of different pieces.
Yeah.
Some we haven't even, I think, had the final word on yet, so there may be some slight tweaks again.
And you guys were able to come up with.
We have a plan.
We have a plan. We'll see if you like it. All right, Monica, let's hear it.
Okay, so I do think I have a little error here, but approval of the previous meeting minutes, I think is on here too.
Yeah, motion.
Second. Great. These are just review from our priorities that we've been talking about. I won't go into them because that's not the primary purpose of this meeting. Our Health First Indiana budget, I'll turn over to Laura just to talk about the high level things that we shifted, moved, and what is included in that budget that you guys saw.
I think last time we met, we did not have our final confirmed number yet from the state, so we do have that now, that for our final confirmed number is $517,550.28. You have to read that part. So basically, since our largest expense is payroll, our personnel, salary and benefits, we propose using that to fund positions. So we tentatively, in that plan that you've received, fund salary and benefits for 90% of the following positions. 2 community health advocates, 1 health educator, a full-time public health nurse, which that would funds our immunization program. This is our immunization nurse, who was fully funded under a grant previously. Project manager, deputy director of finance and operations, and then all of our part-time supplemental nurse and registration staff to run our clinic, which was again part of the immunization grant that we no longer have. And our community health advocates were funded partially under that too. So that's kind of the positions that we propose to fund under HFI. And then if you go to the next slide, we'll kind of talk about the overall 2026 budget. So Monica and I have been working together to identify cost savings that we had in the 2025 budget that we won't need for 2026. And those items being rent, since we know we're moving to the community center, utilities, common area maintenance, things that won't be needed anymore. Moving expenses, we also will have a decrease due to Department of Public Works expenses, because again, we're moving to the community center. And then we decreased our training budget, which still leaves us enough to cover our training needs for next year. We propose shifting our LCSW position to opioid funds, which is only sustainable for 2 years. Shifting our school liaison nurse to co-ed funds, which is almost sustainable for 4 years. The community center has pledged $100,000 to help fund positions, and then the culture of health position will also move under the community center. So that still leaves us with about a $480,000 budget deficit after identifying all those cost savings. And then
But if you recall from last month, it was 1.3 million. So,
correct.
and I think some of the things you didn't outline, like, I mean, the training budget is outlined here, but there were a lot of other things that I think we had in the budget this year that were, I'll call them nice to haves because of that surplus of funding, like we can do this extra thing, and those were all cut.
So we're not losing any people.
We're not losing
No.
any people.
Then we identified another like 269,000 in cost savings, and those 3 bullet points are what make up those. So we have a storage unit that we are looking to move to a DPW facility, not backfilling an open nurse position. And then we would shift costs like in our software and IT costs. And then Parks has offered to supply some of our outreach supplies. PR would take over some of our marketing, and fall prevention supplies could then fall under fire.
And those were costs that those departments, you know, could probably be easily absorbable within their current budgets.
So we're still approximately about a $200,000 shortfall, which the city has committed to addressing during the budget process for 2026.
Yeah, so obviously this isn't our only bucket of money, so to speak. The city has a variety of different revenue streams, and I think the team's done a really good job. We believe in the mission, and so we'll find the additional funding to make sure that we can keep operations moving forward as we intended for 26.
Sorry, keep going. I
Yeah, any
apologize.
questions? Any questions over any of that?
It is maybe more of a broad question, and it's the same one I asked last month. I didn't know if there's any more clarity. Has the expectations, the needle shifted at all on the deliverables we're expected to achieve with this? Because, you know, it was move the needle on these with 1.3 million. Is the watermark the same at the current funding
So
threshold?
the watermark is almost but not quite the same. They have not allowed for any administrative decreases, and the administrative burden is quite high in managing this. And I think every health department is asking for that. That's within the power of the state health department to control. That's not legislative. So we'll see how that continues. They have removed, the legislative process did remove tobacco prevention and cessation from the core services. So none of these funds can be used on tobacco prevention and cessation unless it's within schools or maternal health. Those 2 programs are okay if you're talking about tobacco prevention. All of our tobacco prevention work is in the schools, so you can still continue that work using these funds, but we have other funds, so it's not that critical. And then there's an additional requirement that the Health First Indiana funds can only be used for legal residents of Indiana. So the easiest way for us to ensure that that we know that is partly shifting operational costs to the general fund, to the health fund that's locally controlled. And the other way is not putting 100% of salary, because we don't have any way to verify that. And it's not defined what exactly that means. So at least for now, unless or until there's a better definition, that's our way of trying to ensure that we're doing everything appropriately in accordance with the law.
You mentioned, I'm sorry.
No, go ahead.
So you mentioned other health departments. Have you reached out? Is there a sense of what other, just kind of comparing, trading notes with other county health departments of what are their strategies for meeting this?
Yeah,
gap?
I mean, some people are just cutting positions or not filling positions that they had planned for this year. I mean, there are still a few counties that this was their first year opting in. They weren't in last year, and this is their first year. So they're just in the very beginning stages of building their programs. So they just cut the things that they were gonna build, right? And others are, I mean, everybody's trying to think of it creatively. They're talking about raising fees, right? So we'll talk a little bit about revenue, and that'll be a kind of an ongoing discussion on how do we continue to offset and build revenue from the back end. But I wouldn't be surprised if other health departments raise fees. That is being talked about. At least one health department is talking about, and one county is talking about opting back out because the administrative burden is high and the amount of funds that they receive is comparatively a lot lower.
Right.
So I don't know where all of this is going to shake out in the end. I think most people are still eager to keep the funding, but it's presenting a lot of challenges for sure.
How confident are you that what you submit to Health First, or that, to get the HFI funds will be approved? Like, do they have a
It's-
say in, no, we won't?
No, they really are just approving it to make sure that it meets the requirements of the law, which is the 60-40 split. Like 60 has to be in preventative health, 40, not more than 40 can be spent on regulatory, not more than 10% can be on capital.
Right.
So it's just those things that are outlined in the code as far as what buckets of money have to be in different areas. They have encouraged us, I think, to think about where the funds are going as far as, you know, what the lawmakers are wanting to see more of. So we tried to keep that in mind too, just like that these are really focused on program work and
Right.
really, you know, supporting getting better outcomes in the
Okay.
state, which was the intention. So.
Right, but they can't say, no, we won't fund your financial analyst. I think you have a.
No.
Yeah, your deputy. Right.
No,
Okay.
they're just there to double check that it meets those
Okay.
splits
Okay.
that are outlined.
Okay.
Mhm. And to make sure that we're submitting all the things that we're required to submit. Like,
So no more surprises, you're saying, at that, like surprise, no, we're not gonna fund that. That's not gonna
no, well, not for
Not for
Health
the
First Indiana,
Right.
for the purposes of this particular budget. I
Yeah.
mean, there still are grants, federal grants that the state
Right.
doesn't know, they're pass-throughs. The emergency preparedness grant is, I think, one that we're still waiting to hear about, and that's a July start grant, so we usually would have heard by now.
Will the budget cuts affect our behavioral health resource support program?
We're not right now, no.
So
I think one thing for people to know is that we did cut all the kind of community partner grants for the most part. So we were giving out a significant amount of funding to different groups, and that will be eliminated for all intents and purposes. I believe all of them, Laura?
Yes.
So that was an area that we were pretty active out in the community, trying to support other entities that were kind of accretive to what we were trying to do. And at this point, we talked about it at one of the board meetings prior that we weren't going to increase the amount. Really glad we didn't do that. So that will be a change, and that will be felt by our stakeholders for sure.
Yeah, and we took that based on some of these previous discussions in this, with this group, right? To say, okay, if we're gonna scale something back first, do that. So that was included in that, those large cuts as we went line by line. Okay, what do we do to keep our programming going, to keep our team in place? Because that's the scaffolding everything else is built off of. The one grant that remains for the community or the club grants, and we do have a little short recap at the end of this, just with some fun pictures. And that's because that was donated funds from another source.
Oh, okay, not from that.
Not from Health First Indiana. Yeah, great. Any questions about that?
Just wanted to take a quick moment to directly talk to the administrative burden question that you asked. So I had a meeting with the state regional health directors and then their Office of Data Analytics. And they've pseudo committed, I have to propose, to look at measuring actually what matters in terms of public health outcomes to balance this administrative burden. And so I've been a little over a week ago working through what is it that local public health actually does and how do we accurately measure that so that we don't have Laura or others spending 30 or 40 or 50% effort. Hopefully something comes of that. They've committed a little bit to maybe creating a committee there.
Thank you. Okay.
Thanks for all your work. This is
It's mostly Laura. She through line by line, and I know it's been.
What's
it's been
worse, Laura,
difficult.
arguing with insurance companies or dealing with budget?
We know the.
So.
This is a world I'm used to.
Yeah. So I think two folds here, right, Monica? One, we have this administrative burden of, well, administrative duty, I should say, to approve the budget, proposed budget. But secondly, what this does for our budgeting process as a city is we kind of have a framework now going into the 26 budget that we know what we're going to do. We know what we have to do to make sure that operations move forward. And as long as this board is okay with the program priorities that Monica's proposed, then we have alignment and you can assume that we're just gonna execute moving forward. And we don't really have to bring this back up again. Is that fair, Monica?
Right.
So do we need to take a vote on?
I'm curious, actually, it's one question, and this may be municipal budgeting versus other. I'm just curious. You had mentioned revenue. There was some revenue generating programs. Is that we're not permitted to include revenue in a municipal budget, so it all has to just be based upon public funding?
No. So basically, sources and uses. In our budget, we show all revenue streams.
Okay.
So the health fund sits as there's two buckets to operations of the health fund. HFI money, which is what we're talking about, the significant cut, that's the new money.
Mhm.
And then the other one is the bucket of money that comes from property taxes. So that also actually saw a reduction because of Senate Bill 1,
Right.
but it was pretty modest.
Yeah.
In that bucket also is listed these other revenue streams that this team has come up with.
So that's like vaccine clinic, travel
All that.
clinic, all that. Got it. So it is represented.
Yes.
Got it. Thank you. I appreciate
Yeah,
it.
that's helpful.
And so those two buckets added together still had a gap of 200,000.
Yeah.
So there's another larger bucket the city has that we're saying, hey, we'll from there and put in there.
I just, want to make sure that was something we're allowed to include.
Yeah, we've been trying to keep this very big picture. We've collected all of our revenue sources together. We've, just to know where our true deficits were during the changing legislative session. I mean, we started this process, I think, in January with the governor's proposed bill, because that gave us like an inkling of where this was going to be. And we knew that we were going to have a cut, right? So we started collecting this. I mean, we've been working through this for a long time. Although the 73%, we had been planning on a 33% cut. The 73% was a bit last minute, but we had all the framework in place and all the kind of spreadsheets already built to understand exactly where that left us. So it just was a bit more scrambling at the end than what we anticipated, but we had done all of the really heavy work, I think, well in advance of that.
I will say, closing this out, one narrative that was used a lot at the legislature, and they sent me the data on it, is that if you look around all the public health departments, they were carrying significant cash balances and hadn't really spent a lot of this new money. And so there was an argument being made that clearly they're either not able to come up with programs that this money needs to be deployed for, or they're just sitting on the cash. I think it was to the tune of like $45 million statewide that hadn't been spent. And so, we obviously want to be an example of people that are doing the work, not spending the money, but doing the work. But apparently there are an awful lot that weren't really doing a lot with funds, which makes a really hard argument when it comes time to cut budgets.
Right.
If you don't need it, I'm going to take it back kind of thing.
So revenue projections are included in the budget?
Revenue projections are cautiously optimistically included in the budget, yes, based on where we're at for this year, because they've said that, and we'll talk about that with the clinical services here just briefly, but that's kind of the next phase that we'll be working on is just to get a more accurate projection of revenue and start figuring out where those levers are so that we can set up for 2027. But 2026, here's where we're at. 2027, I think is where we'll hopefully see the effects of any revenue decisions. we
Best way to think of this for everyone is, we went through it. I obsess over revenues, not expenditures, because you can't spend money you don't have. So we figured out reasonably, so what kind of money do we really think we're gonna have in 26? Then we backed into, okay, what expenditures were we planning to have? Where's the gap? And that's the number we had to cut. So good news is if we overperform on the revenue side, then that's just surplus, not deficit, right? If we underperform, then we have some deficit. But honestly, if you look at our revenue streams to date in this particular operation, the lion's share of money comes from either property taxes or this HFI money. The new revenue is encouraging, but we're talking about a rounding error for the most part, for now. Until these guys grow it into the juggernaut that it will be.
Yes.
That's the real health department.
Yeah. Watch out, IU. All right, so we need an official vote on the budget. I'll make a motion to approve the budget.
Second. Okay, all in favor, give an aye. Aye. Against? Looks like the budget passes.
You shall turn it in. Thank you.
Good job.
Thanks to the city for covering the $200,000.
Right thing to do.
So speaking of revenue, I'll let Jen just talk a little bit. Oh, this is to Laura, sorry. And then Laura will pass it to Jen, just as far as where we're at on revenue.
Now, this slide just represents clinic revenue. So if you remember in 2024, our clinic revenue was just a little over 77,000. And for this, from January through the end of April, that blue line at the end represents where we're at so far. We're about 88,000 in revenue. And then the orange is our expenses. So basically this is just like clinic supplies. This does not include personnel, but just supplies. So our vaccines, and things like that. So it's month over month, you kind of see where we're at. The green is the profit loss. So you can see in the beginning, we were at a loss. But we are working our way towards a profit based on expenses of vaccines. So, as demand increases, as our revenue increases, so does the cost because we're paying for all the vaccines. So there is a little bit of profit in there, of total about 8,000, almost 9,000. We do have outstanding accounts receivables with claims filed to insurance of about 23,000 right now. And then just wanted to mention, we did start travel vaccines like the very end of April. So really none of that revenue is captured in here yet because that's all in May, but we've had a total of 24 appointments and our revenue's been just under $7,000. Now we have had the cost of the vaccines in there too, but it has been a good start to that program.
Remind me, you do or don't do like the Malero, the dispenser? You don't have a dispenser, right? It's just vaccines and clinicians and advice and all
So I'm
that?
e-scripting the Malaron.
Okay.
Mm-hmm.
Okay.
Yeah, and then there's been a couple of other things that may come up. I haven't sent any yet, but like people traveling with major elevation changes, then you're going to want preventive for that.
You said no, not travel, not diarrhea, anything like that?
Not typical traveler's diarrhea, but we have had a few where like preventative antibiotics specifically for cholera are recommended. So
Okay.
that, that would be something we consider.
Yeah, I'm just getting on here like all the dollars are. That's great. I mean, that's great that it's again, that narrowed in, like that's getting that kind of revenue off of that kind of a slice is great.
And if Mefloquine comes off a back order, then we'll have another tool besides Malaron. Right now it's just Malaron.
And Laura, do you think on the cost piece of this, that are we as good at that as we possibly can be on the cost of supplies? Is there a procurement thing that because as you learn new things, you can source it better or what have you, like?
Yeah, we are part of a physician buying group.
Yeah.
I think we're still searching for for sources to see if there's something better out there because
Yeah.
some insurance companies are not reimbursing at our cost.
So this is blows my
So-
mind. So an insurance company will not reimburse for the cost of the vaccine that we're administering?
Correct.
How is that?
Don't ask.
So you.
You don't want to know.
I do want to know.
So, are any of the insurers requiring, like, doing like, kind of, I'm thinking like brown bagging and stuff, are they requiring that they bring that they send the vaccine and then you administer the vaccine? Because that happens
Oh, yeah.
all the time, especially with
exact
high
reason.
cost. Yeah,
Really?
yeah, because they procure it cheaper
Yeah, right.
and then they do that with infusions frequently, which are really high cost. Vaccines are cheap actually
Right.
compared to what some of the
Well,
other
yeah,
stuff.
compared to the stuff you do.
Yeah, compared to the stuff we do, it's really cheap. But that's where you'll get into it is
Interesting.
especially, yeah,
So they'll mail it to the person and then say, go get the.
yeah. And so then all you get
Is
is the administration fee, and then the administration fee is not very much, like to the tune of $10.
Yeah.
Yeah.
Most of the vaccines are getting covered. It's just a few insurances are really bad.
Well, the travel vaccines are out of insurance, right? That's.
Travel vaccines are
Yeah.
completely out of insurance, yeah.
Those are the ones that are gonna deny are the travel ones, or they,
That's just all cash, right?
No, there's
No
like.
travel.
No, there's other
Shingles.
vaccine
Is
schedule
it
that
shingles and
don't get
HPV?
covered very well.
It's varicella, HPV. I feel like there's one more. It's the more expensive ones
It's the ones that are.
that they're,
RSV, the
um,
New World.
We don't have a ton of RSVs, so I don't know if we've figured that out as much, because it's very insurance company specific too. Yeah.
Is it, please tell me it's not Anthem, because that's. your
No,
biggest
Anthem, we
one.
love
They're
Anthem. Anthem is very
Yeah.
good with the reimbursement, so,
Good,
so
'cause
we
that's-
get very timely turnaround with
So
them.
it's probably some of the smaller,
And
it's
some of the,
marketplace plans.
yeah, well, that tends to be the problem, yeah. Because they're just,
I do think what's great about like any of these up here on the board is anytime a government can provide a service that people want, need at a convenient, professional manner, and you can offset a decent amount of the cost, that's a win in my book. So, I mean, I'm encouraged to see this program grow. The travel vaccines, I think, is an amenity for our community, frankly. And so I'm encouraged by the number of people that have already graced your doorstep for it.
yeah, it makes sense for us to offer it. I mean, it's, prevents them from leaving all our other
Well, and I think the amount of international travel that's done by Fisher's residents is not insignificant. I mean, the two Holgren brothers were in the Horn of Africa at the same time.
Yeah, that was kind of what, have you seen that picture of the, yeah.
Did you guys actually meet up at?
We had dinner together.
Yeah.
Did you
We
really?
sit on the same floor, two kids from some cornfield, Indiana, met in Dakar, Senegal, and for completely different reasons on the same day.
That's
Totally
wild.
wild. Hey, that's, talk about like your party stories, like, hey, oh, what a small world. I can beat you. But
yeah.
no, yeah, so yeah, we were both in Africa this month, so.
For me, the best part has been living vicariously through all these people traveling.
Hear great stories.
I know, it's so
Traveling
exciting.
Our nurses are like, we're never leaving.
Some of our nurses. She's not even going to Florida.
Yeah.
It's too dangerous in Florida.
All right. We got next, Monica.
Just an update on services here quickly, Jen.
It's a great segue. So we started travel vaccines on May 1st. Through 5/23, we'd had 24 appointments and we still had 3 scheduled through the end of this week. Our goal for Q3 and Q4 is to have 3 per day, which, as we talked about here, the marketing did not start until halfway through the month. So the fact that we had that many appointments just with website updates and word of mouth is pretty amazing. So we're excited about what will happen once we get a little more PR. I do have broken down Fishers residents versus non-Fishers residents. So we've had 10 non-Fishers residents and 14 Fishers residents of the folks that have come through our door. Interestingly, at the very beginning, it was mostly non-Fishers residents, and then it's turned into almost exclusively Fishers residents after that. So just interesting, we'll keep an eye on that. And then at the bottom here, sorry, it was a snip from our EHR, so I have to kind of explain these graphs, but the blue, the bright blue, the majority on both sides are our most common diseases or common procedures that we're doing in clinic. So for both of those, it is like your routine immunizations. The purple color is your second, what we're seeing second highest. So you can see January through April, that was actually screening for LTBI. In May, for the month of May, 20% of our business has been with our travel vaccines. So huge increase that we're excited to keep that rolling. Any travel vaccine questions?
You're anticipating 3 per day, or I would assume that heavy in the summer. I'm not sure if you get many in the winter time. How are you?
Yeah, so we're keeping an eye on that because we think we might want to market specifically to some businesses in around here because yes, we assume there'll be some seasonality with like summer vacation, et cetera. But with how many business travelers we have, we think that there might not be seasonality. Well, that's an average. So, you know, if we have 5 per day for a couple months and 1 per day.
And honestly, the timing is good just because summer is a less busy time for us, like spring and summer when people are prepping for travel. This is good because it fills a gap in clinic busyness. Whereas, you know, fall is all flu vaccines leading into the school year is all back to school. Like, so the timing for travel to fill that gap is good.
Yeah. How are you advertising?
So we're working with our PR team. They've put it out in the Fishers Health Department newsletter, making some social media posts. I know you've met with them.
I think we're close to having SEO, so search engine optimization, because if you're like me, you Google,
Right.
I need a travel vaccine, I'm gonna live in Fishers. We want to be at the top of that list. And so they're working on that. I think there's some website things they need to adjust so that.
And we're already on the CDC side too as a yellow fever provider. So that's, I think, how we were getting our first folks that were showing up before we even had opened.
That's great. See, that might be talking to the schools because they do trips, right? There are certain trips that, you know, international trips they're doing, which may or may not have seasonality because some travel.
Right.
Well, plus there's a massive amount of international students
Yes, there
that
are, yeah.
may be traveling home for
Right. Yeah, something too.
72 languages spoken in our school system today, so.
And an update on the rest of the clinical services. So we did also launch our STI and pregnancy testing. Those were made available starting May 19th. We have not actually had any appointments yet. We have 3 scheduled for this week, actually. So we're excited to see how those turn out. We have purchased medication to treat 2 types of STIs in our clinic, so that we would not need to send that prescription out. The person could return to our clinic and receive that treatment in-house. And then overall clinic expansion. So we're adding additional appointment availability for Wednesday and Friday. We're not changing the times of the clinic. We're just expanding the amount of appointments that are available during that time. Wednesday and Friday are 2 of our day shift times. So we want to kind of iron out the kinks there before we expand into our evening shift hours where our staffing model changes slightly. So our plan would be for mid-July to add those appointment times in the evening as well. Evaluating our staffing model to ensure we're maximizing resources. And then we're also working with Business Solutions Group with the City of Fishers to really help us kind of take a deep dive into that data and make sure that we're, again, matching up our resources and our supply and demand appropriately. Last month, I told you what we were going to be monitoring as we launch these new services. So our time to next appointment, our 30-minute appointments are those like routine vaccinations. Though that average for that has still been less than 1 day. So a lot of times we can do a same day appointment for those. The 60-minute appointments, which would be your travel, your STI for right now, the average appointment time was about 3 days before someone could get in. So we're still keeping track of that to make sure that we're not, that those wait times don't get to be too long.
The 60-minute appointment for STI, is that standard? Or?
No, we're doing that just as we kind of start out at the beginning here to make sure that we have our process down.
That's new to all the nurses.
Yeah. We'll definitely bump that down.
Hoping that gets down to
Once we
like
get-
5 to 15.
7 minutes.
Yeah.
No, I mean, usually it's, hey, I'm worried I have an STI. Okay,
Yeah.
take this test.
Right. So one of our point of care
And then
tests.
take this medicine.
Yeah.
One of the a lot of it's point of care. So like one of the point of care tests takes 20 minutes to run.
And so we have to build in that
I'm
time.
just building that time in.
Yeah. And again, this is, all the education is brand new to the team as well, so that's very time consuming on the front end until we kind of iron it out.
So you're doing your point of care test, you're waiting and then,
Yes.
okay, it's not okay, we'll get you the
Correct.
results and
Right.
whatever.
No, they're waiting in the room. We'll follow up with them.
We plan on having TV screens in the clinic room and then play a, propaganda video about how great Fishers is while they sit there. Just like at the clinic, remember Monica? We had- It'll be me welcoming them. I want to welcome you to the golf department for STI test. Great.
We're also monitoring our vaccine demand, so we have had a couple requests for rabies vaccines, so we have added that per request, and then still monitoring the visits by the day of the week.
Who requested rabies vaccine?
Travelers.
Yeah. Yeah.
Someone who got bit by a bat.
But also, but it's also recommended for travel, like, to, like, if somebody's going and staying with the host family or in a village or something like that, the chances of running into stray dogs is very, very high. So, some people refuse it, we recommend it,
Yeah.
but some people refuse, some people say, yeah, I'd like that, we can order it as a one-off, right?
And I'm kind of surprised because I thought Japanese encephalitis would be the first one that we would see demand for, and it was actually rabies, so.
It's actually really helpful that you do it because if people get the first, they have a really hard time
Yeah, we were actually. just
other than
about that.
going to an
Yeah.
emergency department to
Yeah.
get the next one.
Yeah.
And that is such a pain.
It
You
is.
know, it's, well, like, the most of the time they will come to the emergency department first because they have a
Yeah.
wound,
Right.
right?
Exactly.
And so,
Yeah,
and so then they have the 3-day, 7-day, 14-day shot.
right.
And I'm not sure if is that something you guys would be interested in capturing from the emergency department?
Yes.
You would,
Yes.
Which would be incredibly helpful.
Do they have
because
titers?
the emergency department would love that.
Exactly, yeah, so that's actually, our nurse that kind of spearheaded the travel, that's her next passion project that she wants to
Okay.
take on,
Yeah,
is that, so, and we definitely think it would be a service that the community needs to keep those folks out of the ER, for sure.
We actually cheaper
They're coming back to the ER for their
They
third.
do.
They do,
Oh.
yeah.
Well, because there's really no other,
Like, yeah.
That's wild.
Paying
so,
an emergency department.
Yeah.
copay.
Yeah, I mean, that's.
It's a very expensive vaccine if you go get it in the emergency department.
You have a daily burden of just routine
Right.
vaccinations in the ER.
Right.
Look at flu shots in the ERs.
Yes.
Hepatitis, all kinds of stuff.
Yeah.
Daily.
That we're giving though because they're there, not, they don't come to get it. Unfortunately, they come to get it.
So what's next? We are going to be applying for 340B drug pricing program, which improves access to affordable meds for our clients. So we'll receive a discount on those medications to administer and dispense. It will not cover vaccines, only treatment, so mostly STI treatment. The application window opens in July. We'll be applying for that. We would receive the designation in October. So that's the drug pricing update, and then we're exploring some additional clinical services, and I want to emphasize the exploring. These are not like set in stone. This is what we're going to go live with next. But including latent TB infection treatment, wellness screenings, including blood glucose, A1C, and cholesterol, particularly when we move into the community center and we have significant increase in foot traffic. We would like to promote those. Expanding our walk-in services when we move into the community center, additional STI treatment services, drawing titers for folks that need that either for immigration or pre-employment screenings, and then potentially respiratory testing. So if you can go to the next slide, this is our, again, proposed kind of timeline. These are two-week increments across the top through the end of the year. Starting with travel and STI of when we could potentially launch these. We think this is fairly attainable, but definitely have some program work to do on the back end before we get to that, so.
Yes, it's great.
very good. Thank
Yeah,
you.
everybody, okay, cool.
What do we got next here?
Okay, just briefly, updates on the community health assessment and the priority areas that are kind of coming up.
So as we start to look ahead on how we can act on a lot of the community health assessment complex data while we're concurrently running our survey process, we'll roll out our focus groups and do improvement planning. So there's a lot of concurrent process going on. We've been working behind the scenes. I've merged together a prioritization matrix from standard one in addition to other sources like CDC and MAP to start to look at all this complex data. What is the magnitude of the health issue? And so looking at that, how many people does it affect? What's the seriousness of the consequences, whether that's consequences on the system, so burden on the healthcare system, or on the individual, and then the community. feasibility for public health to be able to find a solution or to build a system with partners to address. And then community priority, which is really, we're in the phase of that part right now with the survey that's going live. There's a large PR campaign behind it, and we're doing our work and then the focus groups to illuminate more there. But this behind the scene work is starting to show some large buckets, 3 priority areas, and with an external health steering committee group that Monica and I have been working on over the last several months. Yesterday, I had them do the activity on this matrix to just get more insight. And so we're starting to see 3 broad areas rising to the top, again, early because we really need and value that community voice. First, behavioral mental health. This is looking at stuff, for example, higher rates. All of this, as I mentioned last meeting, we are relatively healthier than many other communities. In this community, among adults, higher rates of depression, frequent mental distress, social isolation, or lack of social emotional supports. Those different measures can impact 1 in 5 to 1 in 4 adults. There are rising acute mental health crisis needs here and everywhere. We're measuring this through ER presentations, EMS engagements, but particularly among younger adults, 20 to 29-year-olds, that's where we are different from the surrounding community. And then the recurring youth mental well-being needs. Some of this includes behavioral aspects as well, such as substance use. Really here, it's just our rate of adult binge drinking is much lower than other places, but that's the one that is higher among things. We have a low rate of tobacco use, and I just do want to emphasize we have a very low rate of drug use, but some of the work under mental behavioral health can look at that. And then looking at a large bucket, chronic disease prevention and management. This is really where a lot of our action can take place in terms of modifiable risk factors, whether it's for heart health, brain health, kidney health, joint health, obesity. We have higher rates among adults of cholesterol, blood pressure, arthritis, and then thinking of our rapidly growing aging population. This is where we can really get into the work around improving disease management amongst our older adults, and then more prevention efforts with our young to middle-aged adults, and help to address more modifiable risk factors, whether that's through increased health literacy, nutrition, physical activity, engagement, and opportunities for that. And then a bucket that is starting to build together around injury prevention, but thinking broadly around injury, and then access and navigation needs for that. So we know about our older adult needs and the increasing rates of falls there. And we're also looking at there's increasing injury rates for maternal and infant health for some groups of individuals in the community, but then there's also differences in care engagements and birth outcomes for certain individuals in the community, and then also looking at experiences of residents who are frequently using EMS or ER services that may be disconnected from this preventive or supportive care environment that we can help strengthen. And so a lot of this might be around access, addressing those access barriers, helping with that navigation system. And that is some of our most immediately and already concurring work that we're doing, for example, with our fall prevention program, and then starting to build out ways to tackle, for example, individuals who may be frequent users of EMS services and running back-end reports on our EMS system that I've developed for the team. So they can start to actually look at what are the reasons for individuals who use EMS services 5, 6, 7, 9 times in a 12-month period. And last comment is just that early, but it's figuring out what's a guided way that we can start to figure out how we're going to act on these while we then incorporate that community voice through these concurrent processes.
And maybe my question is later on. So first of all, these are wonderful. I love that you've got all these dashboards. This is really, really helpful to have these numbers. Do you do any like specific focus deep dive, like pre-post, any kind of causality establishment? So, you know, we've got really low smoking rates. We've got really wonderful things in terms of like suicide prevention. Do we have any data or do you do anything like a focus program where we can link the outcomes we're getting to the initiation of a specific program?
Yes.
Or is it more just global metrics saying, because we're doing this basket of good things, we're getting this basket of good outcomes? Or do you have a specific, this intervention got us this and it's causal.
That is something I can measure for when I have access to line list data, individual records, and I have specific access points for that. That's largely through our EMS partnership and looking at their EHR. And so I can get both process and outcome measures and start to target those and evaluate them over time so that we can guide refinement of how we do fall prevention outreach and how we do engagement. So those very short-term process measures, I can look at the medium term, how we shift, what we do that program, I can look at. And then I have, it just came in yesterday. It's literally been a 4-month process and I haven't had a chance to tell Monica. The data use agreement, so I can start getting line list data from these databases that the state holds for certain measures so that we can start to do that type of work as well.
Thank you, yeah.
And then there's other work that others are doing. For example, the IU Fairbanks put out the study on the return of investment of Health First Indiana, and it was only from the first 8 months of data and only for 3 programs. So they shared the formula that they used after, compiling multiple studies. So that's where we were able to say, I think we said this at the last meeting too, that we think our fall prevention program has had a $1 million approximately return on investment just by providing those services based on the calculations from this larger study that IU Fairbanks had done.
Thank you very much.
I think we have a good opportunity to make sure that our quality assessment work that we can build out through some of my work and working with other team members will allow us to adapt evidence-based practices into context and evaluate them over time so that we can pivot in a continuous basis to make sure that we're reaching the right people and getting the outcomes we want.
I think it's important for us to categorize the work of the public health department kind of 2 buckets. One is what amenities or services we're providing to our residents, which may not be providing any kind of direct public health outcome in the sense of getting people healthier, but we might just be providing a service that's more convenient, more effective, or cheaper, frankly, or more attainable for folks. The other one, and I think this is to your point that I think is so important, is this idea that we're trying to improve population health. And in those programs, I think it is important for us to constantly kind of reevaluate and question, is this actually having an outcome or not? And those are really hard things to measure, but I think this board needs to continue on an annual basis to evaluate, is this program worthwhile or not, because I think sometimes you get these government mandates that we have to go do these things. So you start doing them and then you just keep doing them because someone told you one time you had to do them. And they're not really achieving anything in terms of population health. So I think we should have a pretty rigorous analysis of those types of programs as we move forward, because otherwise I think you're just doing busy work for the sake of it.
And we continue to analyze those things internally too. Like, let's continue to focus on the things that are important here, right? Like, we don't need to build out a very robust lead prevention program. Right? House was built after 1990, so this isn't that community. So it's a mandate by the state, but we're gonna do what the minimum, but we don't need a very robust program for that. So we continue to look at that, and that's, the purpose of bringing this in front of you guys, so you have an understanding where the data points are, so why we're focusing on these different things.
I suspect that you have enough data, especially if you have line list data, and EMS data, to actually publish something about the falls prevention program that you've done. I mean, that.
We did if we had time for all that, yeah.
No, I know. I recognize that.
We definitely do.
Said the person who hates to write.
Right.
But I mean, it might be worth saying, okay, is there one thing that we're gonna take, time, and I think Kyle and I probably have resources to be able to think about, to at least edit. I'm a great editor. But like, how do you put something out there, because it's actually not generally published about programs like this and the partnership you had, and thinking about, you saw a problem, right? You guys put a lot of intervention in place around a community, and you have ongoing good outcomes now.
Yeah.
And it's a replicable program.
And what we've been able to manage is we have presented at conferences, right? So
Right.
like, if nothing else, let's present here, let's present at conferences, and let's continue to talk about this so that other people, so it can generate and get the word out. But Yeah, I mean, as you know, publication is another level. So, and a lot of health departments are exploring academic partnerships, which is
Yes.
fine. We'd be open to that.
I just signed us up.
So you guys are now signed up, yeah.
That point is like, one of my strongest value sets is data-driven, evidence-informed policy and practice. And I think that we do a really good job at attempting that here. But I think it's as equally important to share that out.
It is,
You know,
yeah.
Monica, as was mentioned, we submitted, before we even started some of the work, I submitted to do a presentation to a National Public Health Conference 2 years ago with the social work team, with this partnership with EMS. Because I agree that example there, is how do you shorten time to action
Yeah.
in local public health? That is easy enough to do, but not often tackled in other places.
And we have resources to be able to put the time in to do it. And the other thing is some public health departments are not resourced well enough to do that, right? So then what they want is somebody to have written it down and
Yep.
said, tell me how to do this. And so I say this at IU Health all the time. You know, if we're doing great work, we actually have a duty
Yeah.
to disseminate it because we have resources to be able to do that. And so it just struck me sitting here, we also have that same duty here but it's not easy. And I'm not saying, and it doesn't.
No, I know.
It's
And I
work
agree
done
with,
at
I
night.
agree with you. Our
It's work
compromise
done,
is
yeah.
go present at a conference.
Yes, go present at a conference, but I will tell you, that's the first step. You
Yes.
had data to get you to present at a conference. It doesn't take a whole lot more, I promise, except on somebody to sit down and write it, which is not fun.
No, it's fine. Generated a lot of discussion. Last thing, fun thing, if you guys would like an update on grants and contracts, I'll turn it back to Laura.
Sure. So good news, we were just awarded 2 grants actually within the last couple weeks. We were all excited. The first one was from NACHO, that Josh worked on. So Josh and one of our public health nurses will be working on this. It's a flexible local epidemiology for X factor emerging diseases grant in the amount of $20,000. It's a deliverables-based grant, so there's these deliverable outcomes that they have to do. They have certain meetings they have to attend with NACHO. And then our social work team, Brittany applied for this community Hamilton County Council on Alcohol and Other Drugs grant for $4,000, which is going to fund 2 staff members to attend adult mental health first aid training, so then they can go out and teach that to the community.
As instructors, and they're both instructors for youth mental health first aid, so this just kind of adds to that.
Yeah, and it's rather expensive training and intensive, so this allows them to do that. And then projects that we have funded, I think I mentioned this last time, Center of Hamilton County, we funded $20,000 this year through our community partner grants. And then we did have one grant that was submitted for the HSE Pickleball Club for our school club grant. That'll go for next year. We're awarded $500. They play out at Dink 24/7 Dink. Yeah. So this helps pay for their court time.
Membership, right?
There.
Yeah.
And then we awarded Iman Schools 2 AEDs in the amount of just under 3,500 through the COAG funds that we have. And then for kind of a recap for 24-25 school year through the School Health Club grants, 395 student and community members were impacted through 4 club grants of about $1,700. And the clubs that were funded were a yoga club at Fishers Junior High. The Do Something Club worked with a memory care facility and then went in and did some activities with them for the Fishers High School Day of Service, helped fund the Riley Dance Marathon Club activities. And then the Fishers High School Cultural Connections Club, they had an international fair that we helped fund as well. And then I think the last page, this is just a success story for the Fishers High School Do Something Club. This was part of their day of service. So that there were 32 students that went to the Independent Village East Fishers. They made 120 sandwiches for unhoused with the residents. They were also able to mingle in the memory care unit. They even took arts and crafts. It was just a great intergenerational activity that built connection among students and residents of the memory care unit.
Size of that club, that's great.
They're doing something.
It's a new thing.
There's an HSC pickleball club.
Yes, and Fishers High School has one too. Yeah.
So the intention of the club grants was really just to promote health, wellness, or service in the community, right? And whatever they could think of in those. So we have a whole like grant application process. We all are, reviewing these, giving feedback. Some of them have taken a couple rounds of feedback, and that's fine. They need to be student led. It's $500 that any club can apply for. So
It's great, just the students are the ones that apply, like
Yeah.
with their teachers, assistants, but it's great to see them kind of take the initiative.
and then they have to report back on what they did.
On
Give
what
us a
they-
picture so that we
Yeah.
can share it with you all.
That's great.
Do they have, do you guys work with the high schools on other clubs that lead like an EMT club or something that?
We don't lead any clubs, but we do have a school liaison, so she's constantly, and then our health educator as well. And so they're constantly connecting with teachers, administrators. They're getting the word out about things to a lot of these things and offering support. It's just a question of who kind of takes us up on it. Yeah.
They were here in our last meeting, right? We had some of the student liaisons, or was that a different program?
No, I think that's different.
Okay.
I can think of, is that Mayor's Youth
Oh,
Academy?
okay.
Maybe,
That's
yeah,
right,
the
yeah.
Mayor's Youth Academy.
We had a couple of
kids,
student delegates who got it.
Yeah,
Um,
that's all I got. Sorry, it was a lot of updates.
quick things here. I think the next meeting, if we could, it'd be nice to take everyone over to the new office.
The community center.
Community center and public health department, show them around. I think that would be good if we could, do that. And then the other, I think, small win we had was our culture of health person. We pulled out for our first triathlon,
Yes.
over the weekend, and, I think we got rave reviews on it.
We did.
As far as I know, I was out there. It was really cool to see. I didn't participate, but I watched. We had 300, participants, and we capped at 300, right?
Sold out at 300. We just did a recap moments before this meeting, and lots to learn for the next year. They're excited. They actually are already trying to book next year and the year after. It's the local Fishers Area Swimming Tigers group. So it's out of Fishers High School. They do a swimming club, and they did a really nice job. A lot of positive feedback. They surveyed all their participants, had a great response. 81 people responded. Mostly very, very positive. A few things that are easy for us to tweak. So.
And what was surprising to me is the breadth and depth of age and body makeup. Like, I assumed this was gonna be all kind of elite athletes, and that was not the case. There were a lot of people that were out there enjoying the activities that, aren't probably gonna win the gold medal. But in terms of achievement, it was pretty extraordinary.
So was it a sprint?
Sprint track, yep. So it's based out of Guys Waterfront Park. They did a swim there. They did a bike, kind of 15-mile bike in this case. I think we're gonna strike that to 12 next year, and then a 3-mile run. Yep.
So anybody looking for a goal for next year?
Yeah.
All right, we're doing another one this fall.
We're doing another one this fall. It's gonna be a Olympic, so it'll be twice that. There'll be an option for sprint, and I think both of them actually offer a variety of other things. So there was a few families that did relays where, one person did each, and you can also do what's called an aqua bike. So just to swim in the bike, or a duathlon, just to run in the bike. So you can do anything you want, lots of options.
Larry was holding out for the Olympic, right?
Yeah, I'm a definite candidate there, yes. Maybe for the aging.
Yeah, there you go.
I'll just add it to August events, there may be a Guinness World Record set for
So that's separate, but
Is
different.
it?
Yeah, are you talking about the Caterpillar?
Caterpillar, right?
Okay, so we were talking about the Olympic triathlon. A few weeks after that, we have our Geist Half Marathon. And Josh is correct. There is a certified Guinness World Record event happening in that event. It's 4 local guys that are trying to be the Guinness World Record holders for 4 people in a caterpillar costume linked together running a sub 1:30 half marathon.
Wow, that's very specific.
That's a nice marathon.
Oh,
That's because the 5 and 6 person caterpillar is already occupied.
You know, we've met with them. I don't know if anyone here has done the guys half, but it's not a PR course. There's a lot of this, but they're really fast. Yeah, they're ready to go. So
It's gonna get really intimate.
yeah.
See the practice run. You guys still need to vice president. Did that get done last time?
Oh.
No, they're supposed to think about it.
Yeah.
Oh,
But, when's the next meeting?
The next meeting that we're required to have is in July.
So, what's
We're gonna
the-
put it off again until.
I think Karen, I nominate
It'll
Karen.
be time to vote again in
Hey,
January.
I made a motion.
Second.
Karen,
Second.
second.
All those in favor?
All in favor? Aye.
Congratulations.
Not a lift.
That was fast.
Her head went.
How does that happen? I don't know.
And just
Show up, just.
Here's my cheat sheet.
Stand in if you.
There's some notes on it.
Keep
Sal gets
Sal,
assassinated.
Yeah, can't be in the same room except for this meeting.
Thank you.